Thank you so much for coming to the 9th International Symposium on Alagille syndrome. We are having just an amazing day, amazing speakers, our wonderful medical partners. Thank you so much to our sponsors for making this happen. And thank you all for coming and joining these sessions. We know it's a jam-packed day, so thank you for, sticking with it. Please remember, you can go in and out of these sessions as you need to, and just come back in. The last 10 minutes of the session, though, it's locked. So if you leave, you won't be able to get back in, and then until the next session coming up. I would like to introduce again Dr. David Piccolo from the Children's Hospital of Philadelphia. And today he's going to be talking about liver anatomy, function, disease, and failure of ALGS hepatic disease.
Thanks very much, Roberta. And I would like to reintroduce my partner in this east-west discourse, left lobe, right lobe of the liver, Noel Ebel, who is going on the second section of this to discuss some common problematic scenarios once we've defined some basic hepatic anatomy. So the objectives of this talk are to introduce liver anatomy, talk about function, review the testing that you see, define a little bit liver failure, and then to summarize which of these abnormalities are more important in Alagille syndrome, and then finally to give you a chance to ask any questions about what, and Noelle has to say this now, even though she did her last talk, the most important organ in the body, at least according to hepatologists. So this is a picture of liver anatomy, and what you can see here is that the liver sits in the right upper quadrant, and it has a complex blood vessel relationship. This is the stomach. This is the spleen. This is one of the major blood vessels, the inferior vena cava, and over here is the aorta. You heard something about particularly this vessel in the last talk. And this, of course, sits under the diaphragm and in the abdomen. Now, this is a cartoon from many, many years ago by Frank Netter. And while it's not exactly anatomically perfect, I think it's beautiful. And it shows you that there's a very complicated 3D relationship in the liver, even more complex than the cardiopulmonary relationship in the lungs, where you have bile ducts, you have veins, you actually have arteries not shown here, and you have these sheets or plates of cells. And these cells are arranged in a way so that they get maximum contact with the blood flow that's going through the liver. And that's really important for all of the different liver functions. And when this relationship is ruined, or in Alagille syndrome, where some of these ducts are absent or deficient, then there's significant alterations in liver function and liver's ability to support basic body function. Now, this is another drawing from Netter, and this one is a cut through a cross section, so sort of at right angles of what you saw before, but in 2 dimensions. And what you see here are the different types of tubes that are present in the liver. And because 3 of these are typically together in one very important functional area, it's called a liver triad or a portal tract. And so what you see here in a normal liver is that there is a vein, there can be there should be an artery, and there in a more mature liver should be at least 2 ducts or ductules. And these are the pipes that carry the bile out of the liver and down into the gut. And they're connected to these sheets or plates of cells where these cells secrete into canaliculi amounts of bile and a number of other things that are carried in bile. And then they're conducted through canals of Herring and into the ducts, and then down through a tree of ducts to finally get to the common duct and to the gallbladder. So now we're going even more micro, and we're just looking at 2 liver cells. And what I want to point out here is that on the blood side of these cells, there are a number of very specific transporters, molecules that push things in one direction or sometimes bidirectionally. And then the liver cell processes these things. And then the liver has a number of pumps that push things in one direction into this canaliculus. And this canaliculus is the smallest diameter, smallest part of this entire biliary drainage tree that does all kinds of amazing things. But one of them is to get rid of toxins, bilirubin, other molecules that the body needs to eliminate into the stool. So in one of its functions, the liver is like a kidney. It processes things, pulls them together, puts them in a tube, and sends them out. Sends them out in a different way than the kidney, obviously. So this is a little bit like what Dr. Feinstein was talking about in the pulmonary artery. And what you have is at the very bottom of this chain, a much wider diameter single tube, and then it branches and branches and branches and branches again, so that the time you get up to this smallest set of tubes, and this is the area where Alagille syndrome has the problems, these are very, very, very small tubes, but because of the branching, there are literally millions and billions of these in the liver. So this is this process of development, and remembering that the liver, like the heart, is much smaller in a fetus or in a newborn than it is at age 2. The liver has to grow, and the liver mass grows, and the bile ducts grow, and as they grow, they branch more and more, and you should get more and more ducts in those lobules, in those portal tracts with age. And that is the major defect in the liver in Alagille syndrome, is that you don't have an adequate number of those branch ducts going all the way out towards the periphery. And as a result, everything that is downstream on the ducts can be much smaller, or what we call hypoplastic. It's a river with less flow, and so it isn't as thick and prominent as it would be in a normal. Now, these are just regular pictures as the pathologist would see them. And here, and I think you can see my cursor, we're looking at a portal tract here, and you can see that there's something here and there's something here, and these are in one area. Blood from the artery and the vein flows in this direction and comes down to a central vein, but the bilirubin drains in this direction, and the duct drains down from that area. This central vein goes into bigger liver veins and goes to the heart, whereas this goes down to the gallbladder perhaps and down into the bowel to be passed out in stool. And these are just higher picture. But when a pathologist looks at a liver biopsy in an infant with Alagille syndrome, these are the things that they're looking for. So the pathologists have a lot of very fancy stains, and for a long time, these were like the most important things in diagnosis. But what you can see here is that this stain highlights different structures, and you can see very clearly, and you can count the bile ducts. This stain highlights the sheets or the plates, and you get this sense that there are sort of multiple longitudinal pathways, almost like a maze, that the blood flow is going through. So we talk about paucity of bile ducts, which is an absence or a decrease in bile ducts. And the numbers aren't really specifically important, they are to a pathologist. But in Alagille syndrome, the ducts can actually have a normal number early in life, even if the infant is symptomatic. And when this was all started, and for about 20 years, there was a lot of controversy about how many ducts did a pathologist need to count in order to say that there was paucity. We didn't have genetic testing. We didn't understand other parts of the syndrome. So this was absolutely key. And so in the beginning, many patients did not get a needle biopsy, which only gets a couple of portal tracts, but rather they would get open surgery and they would have a wedge of liver taken out so that they could get enough portal tracts to do this. So we've come a long way from this, and actually now demonstrating paucity is no longer critical for making the diagnosis of Alagille syndrome. So that would have been heresy when I was a fellow, but now it's a rare patient who actually gets a liver biopsy at the time of diagnosis. Not, maybe rare is a little overstated, not so common. Okay, so then we go to the vasculature. And so this is vasculature in the abdomen. And we're looking at liver, upper right. Remember, we're looking at the patient as we would see them in real life. The spleen, and the spleen's blood flow, which comes from a spleen artery mostly, goes and it comes back over to this portal vein. And the bowel blood flow, which comes from an artery coming off the aorta, comes back through these mesenteric veins, and there's some drainage from the wall of the stomach, and these all come together in a portal vein, and portal means door or to carry, sort of like portaging a canoe or the door, the gates to the liver. And all of this blood flow should travel freely and low pressure into the liver. And the liver is one of the very few places in the body that gets blood flow from an artery and it gets blood flow from a vein. And in fact, the venous blood flow to the liver is much more magnitude than the artery blood flow. So the artery has oxygen and it's high pressure, but the vein is draining all of the gut and the spleen. And that's very important because if you eat things that are toxins or other things in your gut, the liver wants to be there to filter it, to clean it, to take up some of those things before it sends them up to the heart and the brain. So this arrangement is really important. And when you have liver disease, you have all kinds of problems with this. So liver abnormalities as far as blood flow or what's called portal hypertension. That means that the pressure in that portal vein is increased. That's what the word hypertension means. But it's different than the kind of hypertension that everyone else talks about, where you get a blood pressure cuff and you have an arterial hypertension outside of this area. This is a venous pressure hypertension. It's a much lower number, but it actually has extraordinary consequences. And it can happen from a number of different things, but when we're talking about Alagille syndrome, we're mostly talking about disease in the liver itself. When blood flow is blocked going downstream, just like if you dam up a river, then everything upstream gets expanded and bigger and higher pressure. And one of the things that's upstream is the spleen. So you get splenomegaly, and that's something that we pay very close attention to in physical examination. And then the other thing that is upstream are the esophageal veins. And when they expand, they are very, you heard in the last hour, thick-walled things and thin-walled things. They're thin-walled. And so when they get a lot of pressure, they expand a lot. And when they expand a lot, they can actually rupture and cause life-threatening bleeding. Also, sometimes in this, the pressure is so high that the blood just wants to bypass the liver and go a different way. It can make even its own shunts. So this is a picture that shows that there's the blockage over here in flow through the liver. So everything else upstream gets expanded. And sometimes the blood flow even goes in the opposite direction. This is a picture of what Noel or I would see when we're scoping. This is a normal esophagus. These are mild swollen blood vessels in the esophagus, and these are much more expanded blood vessels. And right after lunch, we don't really show any pictures that go any further along that sequence. You also get increased blood pressure in the vessels of the stomach wall, and we can see that on a scope as well. And it can bleed, but it's not the same magnitude as bleeding from the esophagus. So the liver has a number of processes and it has definitions. And so liver disease, abnormality with the liver, hepatomegaly means enlarged liver. Hepatitis usually means inflamed or damaged liver. Steatosis is a fatty liver. Fibrosis, a scarred liver. Cirrhosis is badly scarred and rearranged and regenerating. A shrunken liver is sometimes scarred and receding. And splenomegaly is the word for an enlarged spleen that usually, but not always, is from portal hypertension. So commonly your doctor will use these words and fly right by them. Now they're the definitions. So what are liver functions? The liver is a filter for things that should be taken out of the bloodstream. It takes up toxins. It also takes up nutrients. It detoxifies things. Tylenol is one, alcohol is another, but there are literally a nearly endless number of things that the liver wants to detoxify. It runs a lot of our body's metabolism and regulation. The liver is a factory that synthesizes things for the body. One of those is albumin that we're always watching as a lab for Alagille syndrome. The liver secretes many of these things to the body, and it excretes many of these things into the stool or into the duodenum, some of them to get rid of them, and some of them for very important functions like bile salts, which, although the bane of existence sometimes, are actually really, really important for absorption. So I'm just going to give you one example, speaking of bane of the existence of every medical student, which is all of these very complicated metabolic cycles. But just to give you an idea of one of, hundreds of liver functions. So when we break down protein, we make ammonia. That's this molecule. And ammonia is very toxic. And all organisms, birds, humans, have some strategy for getting rid of ammonia. We transfer it to the liver, which takes it up. And that process involves aminotransferation, which is the big word in these liver, people call them function enzymes, alanine, aminotransferase, and so on. The liver takes this up. It uses energy to detoxify the ammonia, and it makes urea, which is this molecule, similar but very different. And then the liver puts that back into the blood, and the kidney excretes it into the urine. And this process is extraordinarily complicated. Many, many people memorized it for midterms, and almost no one remembers it after finals. So when we talk about liver function, people use this word loosely. And Noel and I will talk a little bit more about function for real. But there are damage tests that are ALT and AST. And sometimes in Alagille, they don't really show a damage that means the same thing as it might mean in hepatitis, but we measure it every time. And then there are bile duct damage tests, such as the GGT and the ALK-Phos. And then there are measurements of elevated excretion defects. And those are things that we measure like bilirubin, cholesterol, bile salts, certain toxins, and metals such as copper. We also look at an enlarged liver, but it's not of the same importance as it is in some other diseases. And we're always concerned about abnormal blood flow through the liver, enlarged spleen, portal hypertension, varices, and so on. So the elevated liver cell damage tests, ALT and AST, and the duct tests, GGT and ALK-Phos, are damage, and everybody calls them liver function tests, but they're not really function, okay? So the liver function tests are a low albumin. The liver can't synthesize blood proteins, abnormal clotting. And in Alagille, that's complicated because the clotting might be abnormal because the liver can't make most of the factors, or it might be abnormal because it's low in vitamin K. And that's the much more common scenario. There could be poor metabolism of medications. And so sometimes we dose adjust those. And then elevated bilirubin is sometimes just excretion. And sometimes as the liver is failing, that goes up more and more. So these are complicated, and each has a second reason why it might be abnormal. But these are the things that are more representative of liver function rather than damage. So how do we measure progression of disease? It's this progression of the values over time that matters more than an individual value. And usually in Alagille, the progression is slow and it goes up and down so that you can't really in any two measures say things are worsening or things are getting much better. But usually it's slow and predictable. And then the one very unusual feature of Alagille syndrome is that some patients who have dramatic defects in excretion between 18 months and 4 or 5 years of age, then their excretion improves dramatically and they get better. And that's something that, for instance, would never happen in biliary atresia. So what constitutes liver failure in Alagille syndrome? It seems like this should be easy to really define, you know, as on this side making it, on this side failure, but it's really shades of gray. But we look at the ability to clot when we're giving enough extra vitamin K, inability to maintain your albumin, ascites, fluid in the abdomen that can't be controlled, variceal bleeding that can't be controlled, encephalopathy and liver coma. That's always an indication that the liver's not working, except sometimes in like a big infection, and a progressive course leading to failure of multiple of these indicators. And I think as we've gone through decade by decade and liver transplant has become better and better, we've moved the bar a little bit to when should we make a move to transplant? And you'll hear a lot about that tomorrow. So save those questions for that. Other things that are failure issues, and some of them are a little bit different or a little bit unique for Alagille syndrome: quality of life, inability to grow despite delivering nutrition, severe pruritus, which is obviously a very tremendous problem in Alagille syndrome, and severe bone disease and fractures. So the decision to transplant the liver is complicated. It's individualized. We'll have almost an hour on it tomorrow, but we recommend it when the progression to failure is inevitable, when the complications are untreatable or unacceptable, when the risk of the disease outweighs the risk of transplant. Because transplant does have risks, and sometimes it has a mortality associated with it. When the positive and negatives have all been considered and reviewed with your practitioner, with the family, with the patient, and the decision is just harder in Alagille syndrome than it is in many other pediatric diseases. So this is a picture of the cut surface of a liver showing the different types of drainage tubules and their anatomy that you would see. This is the first International Family Symposium. I think we were an awful lot younger then. This is at CHOP, and now we're going to go, if I can have Noel join me, and we are going to do some clinical questions to start the discussion. And then someone, the moderator, will pick up any questions in the chat that we can add to this discussion. So, Dr. Ebel.
Yes.
My 15-month-old child was just diagnosed with Alagille syndrome by one of the gene panels. And the first thing that's happening is I'm being sent for an ultrasound. They didn't tell me much about it. What are they looking for? How do I interpret it? And what's it going to tell us?
Great. So there's a couple of things that we look for on an ultrasound. And I guess if anyone's been pregnant or gotten an ultrasound before, their child's gotten one, they've looked over at the screen, they say, that's a lot of black, white, and gray. What are you seeing? So it's a very good test for some things, but maybe not the best for others. So I guess the couple things that we look for on an ultrasound. So one thing that, like Dr. Piccolo was talking about, was the size of a spleen. And often I feel like the spleen gets ignored, but as liver doctors, we really care about it. So your liver's on your right, your spleen's on the left. And you can think about, the way we think about it is if the spleen is getting bigger and bigger and it becomes abnormally large, as Dr. Piccolo mentioned, the reason for that can be that there's some scar in the liver. So you can think of like the heart pumps your blood, it goes back through your liver and back up to the heart. So if you have scar in the liver, it's kind of like squeezing a garden hose and that pressure is going backwards. And the spleen is like this water balloon that keeps getting bigger. So it's one way we can start to say, is there a little bit of scar in that liver that's causing the spleen to be big? So it's the first thing you can see on an ultrasound. Other things that sometimes it comments on is maybe the smoothness of the liver, and that's not a perfect on an ultrasound. There's other tests like a liver biopsy, for example, or maybe a different type of imaging like an MRI that can give you a little bit better characterization, but sometimes it'll say the liver looks nice and smooth, which is how it should look. You know, it should be a big juicy sponge that's smooth, versus if you think of the most scar a liver can have, or a liver with cirrhosis can have sort of more of a bumpy surface. But again, not the best on an ultrasound. And then from all those pictures Dr. Piccolo showed, it shows you the vessels that go into the liver. And those are important to us in thinking about, is everything flowing the right direction? So is it actually flowing through the liver versus, again, that squeeze of the garden hose, and some of it starting to flow in the wrong direction, backwards, away from the liver. So it can show you how everything is flowing. And again, that gives us an estimate without a liver biopsy of how much scar there may be. And one of the last things we can see on an ultrasound, well, there's a couple things, but related specifically to Alagille syndrome, is something called elastography, or you can think of it as a way, it's like a stiffness score for the liver. And again, not a perfect test, but it can help you and something to track over time, meaning if the stiffness score, you should have like a sort of normal, there shouldn't really be stiffness in the liver or scar. And so if that stiffness score is getting higher, it may be a piece of information to help understand how much scar may be in that liver as you're thinking about what size is the spleen and all the other things, the blood tests that you know about that child.
Perfect, thank you. Dr. Ebel, my other child, a 16-year-old daughter, track runner, who's running out in the West now in this 110-degree weather, has been having muscle strains, muscle cramps after her running. She has a little bit of a big spleen, and she vomited blood, and we're in an outside hospital now being transported into Stanford. And I want to know what you think might be going on and what kind of therapy might you be able to do to fix this problem.
Yes, so the buzzwords to like bring home everything Dr. Piccolo was saying. So you say a patient that has a larger spleen. So now we're thinking that could be a sign that the liver has some stiffness or scar. And if you're thinking back to those pictures Dr. Piccolo showed, it's if the liver is starting to get scarred, then you're at risk for something called we call esophageal varices, but by esophagus, I mean the tube that connects the mouth to the stomach. And as the liver is stiff, the blood that's supposed to flow through the liver tries to find other pathways around it. And in doing that, these veins that shouldn't really be here near the esophagus start to get bigger, can get bigger and bigger, and they're really fragile, so there's a risk of bleeding. So for any patient with Alagille syndrome or any liver disease in general, if you're worried that they have scar in their liver and they're at risk for varices, vomiting blood is always the first thought to us is this, we call it a variceal bleed. And we think about it that way because that we think of as more of a emergency, and that would be something where that patient would most likely get a camera exam. So we say like a scope or an endoscopy, and thinking back again to Dr. Piccolo's pictures where he said, this is the normal smooth esophagus. This is the next one with a little bit of varices, and this is one with even bigger ones. So that could be, if that patient were to get a scope, if you were to see that and you can tell, is it actively bleeding? Does it look like it bled in the past? Or does it look totally okay? That camera exam is the best procedure to be able to just directly look and visualize, and not only to be able to diagnose what's the cause of that bleeding, but to act on it and do something to stop that bleeding directly. Again, a patient with liver disease or Alagille syndrome that could have a variceal bleed, that would be the next procedure to sort of look at it and treat it.
Great. Dr. Ebel, I took my 4-year-old, we moved from a National League city to an American League city. And when I got to the new hospital on the first visit, they told me that my 2-year-old's liver was failing, whereas the other hospital said the bilirubin is up, but you're doing well. Can you give me some advice about what are the things that I should be thinking about? And are we heading to transplant next month, or are we holding out for our new hometown team to get the World Series?
I love that question. I think it's like really good to talk about that language, because sometimes when families or even other physicians or non-liver doctors talk about the liver failing, for us as liver doctors, it means really something really specific that Dr. Piccolo is mentioning. So I think to like orient us around that language, I'll start by sort of defining when we say liver failure, to us that means, you can think of it as like a sequence of events. So it's like a liver that's totally healthy, and then a liver could be starting to develop some scar in it, and the things that the liver is constantly producing, like bile and other things, start to back up and cause some irritation, which is leading to some of that scar. And as the liver is not able to drain, then that patient can become jaundiced or yellow. And then as you like keep moving through a patient that has maybe now some jaundice and their liver's becoming more scarred and it's cirrhotic, meaning the most scar liver can have, then after that, you can start to develop some additional complications that Dr. Piccolo was mentioning. Now, do you have varices that are at risk of bleeding? Now, do you have some fluid in your belly like ascites? Now, are you getting sort of infections of the liver and other things? And then as you sort of move through that sequence, sort of when we say end stage liver disease and sort of liver failure, for us as liver doctors, that means that now the liver is having a hard time making some of the most important proteins, and there's blood tests that show us that. But specifically, like, is the liver no longer able to make some of the proteins that helps to clot the blood? So we think about, what is the INR? Is the INR getting really high, which is a sign that the liver is having trouble making that protein to clot the blood? Is the albumin really low, another protein that the liver makes? That sort of helps us define like what liver failure means. So when you're thinking about between two different institutions, you can think about, are we using the same language? That's really what we're talking about when we're talking about liver failure. And then as you think about the progression to liver transplant, it's thinking about, is the liver have so much scar that it's not able to recover from that, so cirrhosis. And now are there complications of that, of cirrhosis, meaning the infections and the ascites and the variceal bleeding and all those, and like Dr. Kamath will talk about and Dr. Piccolo talked about, all those can be indications for transplants. So that's sort of the progression that we tend to see, and those are the times when we start to think about liver transplant for a child.
Great. Dr. Ebel, my 3-year-old, someday to be a star athlete, fractured her leg without too much trauma, actually. She wasn't playing tackle football. And the doctors for the first time got a vitamin D level, and it was 5. And they said, this is horrible, and put her on a combination preparation of vitamins A and D and E and K. And 2 months later, the vitamin D level is still 5. The cast is still on. What are your thoughts about what we should do, and why is this happening?
Yeah. I know Dr. Piccolo will have a better answer to this question than I will, but I'll give it a try and I'll start. So first, some children with Alagille syndrome, so they are more likely to have some bone disease related to that syndrome. And then you think about the child also with liver disease who might have jaundice. And when we're starting to think about that child with jaundice, or we call cholestasis, it just means like the bile, again, is not able to drain the liver very well. And one of the jobs of bile that the liver produces is to help you absorb certain types of vitamins. We say fat soluble vitamins, and those are A, D, E, and K. So if anyone knows, like it's like Aquadex has all of those, or like Decus has those, and it's easy to remember because like D, E, K, A, all the vitamins that you need. So in a patient, probably all of us are vitamin D deficient, but specifically in a patient with Alagille syndrome and or a patient with liver disease that isn't able to absorb those vitamins as well, they need repletion of those vitamins or something that they're able to take. But often, you're thinking about you're giving 4 vitamins all at once, but that doesn't mean that that's giving you all the vitamin D in this example that you need, and you may need additional beyond that. So I think the example that Dr. Piccolo and I had talked through is you can keep increasing it, but you don't want to give too much vitamin A, for example. You just want to give the extra vitamins. So some of our patients are just on the Aquadex. Some patients are on Aquadex plus vitamin D. Some are on Aquadex plus vitamin D plus vitamin K. So we think of it as like additive to treat that vitamin deficiency that we're really trying to get a hold of.
Great, thanks. And there is that special vitamin D that the kidney doctors love, which sometimes rescues us when the regular Ds don't work. There are a few questions in the chat. Dr.
Piccolo, I do want to let you know this session will close automatically in like maybe 1 minute.
No pressure.
I'm so sorry.
The answer to the question about the ultrasound at 4 months, will it always predict that the ultrasound would be great? The answer is no. Repeated physical exams, repeated ultrasounds can help you understand the progression, and sometimes the spleen might expand at 2 years or 12 years. If you have a finding of splenomegaly in an adult with theoretically no liver disease, there are 10 different things that cause splenomegaly, 10 different processes. But if you have a spleen and you don't have mono, you should have it looked at and watched. It doesn't mean you have to do all kinds of things in 2 months, but you have to pay attention to an enlarged spleen to know, is it related to the liver or the blood system, hemolysis, infection, all these other things. So finding an increased size spleen in an adult is an important thing to pay attention to. Not always does the liver doctor have the answer. With that, Roberta, are we closing shop?
We can keep going till she dies. Keep going.
All righty.
We have, okay, Noel.
Any other questions? Pop in.
I do have a question if we have a quick moment.
Go ahead.
Fire away.
My son recently, his liver doctor told me that his platelet count had dropped, which could signify issues in the spleen. So we're going to have repeated blood work in about 2 weeks. So I was just curious how that ultimately affects or something that needs to be looked.
Right. So that is the common blood finding of an increased spleen, is that platelets get, we say, trapped in the spleen. And so when the spleen gets bigger and bigger, the platelet count can go lower and lower. And as Dr. Ebel said, looking at an ultrasound that looks at the blood vessels and measures the size of the spleen is helpful, and repeated measurement. And I think liver doctors believe that our hands are the best measure, and ultrasonographers believe that their ultrasound is the best measure. But those two things can be related, but you can also have a one-time drop in platelets from other things, ranging from immune things to viral infections. So you're watching the progression over time. But a platelet count that was 250, 225, 200, 150 over the course of a year or 3 years is usually a sign that the spleen is getting bigger and it's trapping platelets. And sometimes it will trap the white cells, and the white cells will go down too, so that the white cells might be low. And also there are some blood cells in there, but it's less likely to cause anemia, low red blood count, than it is to cause low platelet count, which is called thrombocytopenia. And that is a common part of a significantly enlarged spleen.
Thank you very much.
Next up, we have ALGS genetic expert, Dr. Nancy Spinner. I'd like to thank Dr. Piccolo and Dr. Ebel for this wonderful session. We know this was a kind of a short one. We are taking the questions and building them into a document so that all these can be answered over the next, through the evening and into tomorrow as well. So please don't hesitate to go into the chat area outside of this and leave any questions that we missed in there. We'll make sure that you get your answers. You'll log out of this and go back into the auditorium and head into Dr. Nancy Spinner's session. Thank you, guys.
Thank you.
Thank you. Good luck, everybody.
Good luck. It's a lot of hopping back and forth, but I think we're getting it.
I hope so.